All right, we might get started, and I just wanted to welcome everyone for coming into Peter Mac today. I know it's sometimes hard to negotiate parking and coming into the centre, but we're really very excited about having you here. We'll be recording the sessions today, so if any of you have any issues, just let us know. We do have a special demo today. It is a bit of a family affair. So part of the session today, for those of you interested in allergies, is we're going to be demonstrating how allergy testing is done in the clinic with the skin prick testing. And my sister Steph has kindly volunteered to do that. So she has allergies and is being treated for cancer at the moment, has very kindly agreed to participate, and that'll be happening in about 45 minutes or so. We'll have a little break in the middle where you can have a drink and something to snack, and afterwards we're going to be hearing from our vets and also from Olivia Smibert, one of our ID physicians and PhDs who studies things like the gut microbiome. What do antibiotics do to your gut? Really interesting area. Lots of our patients are always asking about it. But before we start, I wanted to do a welcome to country. I think it's really important to recognise the land which we're on today and the Aboriginal Torres Strait Islanders past and present. We no longer say emerging, so we recognise that we're on the First Nations land. And I really like to show some artwork just to show you just how beautiful it is and how much we can learn from our First Nations people in their bush medicine. So my name's Kas Thursky. I am a professor of infectious diseases. I work with cancer patients and I research in various spots around the precinct at the Doherty and at Royal Melbourne. And my interest is in how we can improve how we use our antibiotics, both in animals and in humans. And we have a fantastic research group called the National Centre for Antimicrobial Stewardship. It's a big word, but basically it's human and animal researchers working together. We call it One Health to try and improve how we use antibiotics. Now, in the media over the past week, it has been Antimicrobial Awareness Week, and all of you would have seen some pretty scary sort of headlines like, you know, superbugs and war on superbugs. And we want to take that fear away, because I don't think talking about antibiotics and associating with fear is a good thing, because antibiotics are actually really important. We do need them. We need them to treat our infections. We need them to treat our animals. Sometimes we need to use them to prevent infections in our high-risk patients. So our goal today is to make you aware of why antimicrobials are important, not just for us as human beings, but also for our animals and our children, and also to understand how they fit into society, because they're one of the great inventions that have actually changed the world as we live. You know, if you can think about what would have happened before antibiotics existed, we wouldn't have cancer treatments that would survive, or surgery where patients would survive. So they play a really important role. But I also want to do something before we start today, because we often don't recognise some of the teams behind the scene that actually do the work to put events like this together. So I'm going to ask some of my team to come up to the front before we start. Now, some of these people are amazing researchers in their own right, and clinicians as well. So I'm going to get you all to come up and have a wave to everyone. So Kaz Chen, have a wave, show your mask. Zohar, Rachel, she might be out somewhere. She's our fantastic coordinator. Nicole Singh. Ron was out at the front desk, actually, would have met his smiley face. Elise. Belinda Lambros, where are you? Now, Belinda is actually is the first ever APRA accredited nurse practitioner in infections in cancer. So she's really playing an amazing role here with us at Peter Mac. And where are our vets, Laura and Ree? Are they here? Yep. Oh, there's Ree. So Ree, Laura and Shree is the graphics that you saw today were done by a very special graphic artist, but she's had to take her husband off to the ED, so she's not here. So, and then last of all, Courtney Irano. So Courtney's going to come up and take over from me now. So Courtney, she is a senior antimicrobial stewardship pharmacist. So what that means is she's been trying to understand the best way to use antibiotics in surgery, because we do need antibiotics in surgery, but they're sometimes not used as best as we would like. So that's her area of interest. So I'm going to ask Courtney to take over to introduce our very first speaker.
So do you want to go through your resources?
Oh, yes, sorry. Thank you for reminding me. Now, while you're watching, we do have a, I don't know what's that there. Oh, no.
Yes.
Oh, yeah. So we have a website, NCAS has a website, and one of the things that we like to do is to make sure that we have consumer-facing resources. This particular infographic, which explains what an antimicrobial is, also the antimicrobial is sort of a bucket term to talk about all the different sorts of antibiotics. So you would know an antibiotic as Bactrim or Keflex or something you've been given for a urine infection or something like that. Well, there are some other classes of antimicrobials that we also use for our patients. So we have antivirals, so if you have a cold sore, or antifungal. So those of you who've had thrush and had to get some fluconazole over the counter, that is called an antifungal. And then, of course, there's antiparasites, and we don't really like to talk about that, but they're sort of things like worm infections and things like that. So we do have 4 different classes of antimicrobials that we use. Now, all of those are really, really important. Often the focus around superbugs is around the antibiotics, but we also know that we need to be conserving and using the other drugs as well. Also, we have just redone our consumer leaflets, really. So you will often be given an antibiotic by your GP, and so you may or may not be given some information about those antibiotics that explain to you what they do and how they work. So these are our patient leaflets you can download. These are some of the more common ones that are being given for urinary tract infections. So they're freely available to you. You can take them. The GPs have access to them as well. So hop onto the website. There's lots of interesting consumer information for you. So I'm going to stop there and I'm going to hand over to Courtney.
Thanks, Kaz. Do I change the presentations or click through? Perfect. Thank you. So our first speaker is Mark Davis. So Professor Mark Davis is a social scientist, and he'll explain a bit more about what that means. But basically, it's about studying and understanding human behaviour and societies and how they understand various aspects of life. And in this, what we're talking about today is how we talk about antibiotics. So thank you, Mark.
Thank you very much for inviting me and organising today. Thank you, Kaz and all. I am a sociologist, so I'm not a medic. So if you're looking for the medical input, you'll have to wait a few more minutes. But I've been asked to talk about, because this is a public lecture and we're trying to talk about our science in a public way, I've been asked to talk about how we talk about antibiotic use in everyday life, drawing on some research that we've done, both with NCAS, but also colleagues at Melbourne, Strathclyde, Copenhagen. And I'm drawing on research that's been funded by the Australian Research Council and also by Health Protection Scotland. So I have colleagues working on antimicrobial resistance and communities in Scotland as well. So what I thought I'd do is look at 3 things. Talk a little bit about news media. So if I'm thinking about how we talk about antibiotics in the world out there, I guess media is an important place to start. How is the news media informing us, or not, as the case may be? How's the news media carrying the stories of antibiotics and therefore influencing us? Then I want to look at a little bit, not too much, at some research that we did to try and understand how non-medics, non-clinical people out there in the world explain resistance to antibiotics. And what are the common kind of assumptions about the body and health and infection and immunity and antibiotics that are there. And then I've got some stories generated in our qualitative social research, looking at the lived experiences of the kind of stories that people have about their own lives with antibiotics and infections. And I think there are some important insights for all of us thinking about how to influence policy and practice around antimicrobial resistance. So the first slide I have here, this is to kind of prove I'm a scientist. I've got numbers and a graph, so, you know, but it's not actually very sophisticated. It's very easy to generate. But all I did was look to see in all Australian printed and online news for the last so many years, 5 prior to COVID, and put in some common terms that the news media might be using to anchor stories about antibiotics and so on. I think there's some important messages here. Where is antimicrobial resistance relative to the word antibiotic? And this other word, superbug, which we often see in the news media, traveling in a very kind of low pattern of kind of, you know, media representation, basically. During this period, well, in 2020, just to kind of put this in context, I also put in COVID to see how that compared to discourse around antibiotics and antimicrobial resistance. There were 500,000 news items in Australia across news and online that had the word COVID in it. And I couldn't get onto the graph. I didn't have that kind of skill. So it's not a prominent news story. And I think there's messages there about where we go to try and influence publics around antimicrobial resistance, or how we influence politicians to do something effective about this scenario. We've also looked at the kinds of, not just what, you know, whether or not antimicrobial resistance is actually talked about, but how they talk about this story, this kind of problem across news narrative. So this is looking at the storytelling, you know, the before and the after, the event, the characters, the fates of characters, carried in particular news items and across the news. And we found that really the dominant story by far in terms of content and also power was scientific discovery. So when the news does talk about antimicrobial resistance, it's about a scientist or a medic pioneering a new diagnostic test or treatment, or an award for a scientist who's made a breakthrough. So the news media narratives are very scientized. And, you know, I'm framing this as a kind of scientific discovery narrative, perpetuating this idea that science will solve antimicrobial resistance. And given that antibiotic is a bigger term than antimicrobial resistance, there are some messages here about, you know, how general publics absorb this storyline, which is scientific, and it's about science will triumph over antimicrobial resistance. So I think this is another problem for influencing general publics and politicians about this urgency of this kind of creeping and slow pandemic. So the other thing we've done is turn to actually how people out there in the world think and feel and talk about this notion of antimicrobial resistance. So we interviewed nearly 100 people in Melbourne, inner, outer, different ages, a mix of genders, people with tertiary qualifications and without, people who'd come to Australia recently and spoke different languages at home. And we found that there's kind of mix of public understandings of this scientific kind of problem, this medical problem of antimicrobial resistance. So most people have what we call a partial explanation. They gesture towards this notion that there's something going wrong with antibiotics, but they can't really explain it in the way that, well, I can't fully explain antimicrobial resistance because I'm not a microbiologist. I mean, the science is so profoundly complex that expecting publics to actually be able to grasp it and communicate about it is a kind of a big ask. So some had what was moving towards orthodox kind of ideas about antimicrobial resistance, but these were people who had a science background or a health background. Another dominant kind of way of explaining this problem of resistance, though, was personal immunity. So across this project and previous ones I've done around swine flu, COVID, HIV, this notion of the body as something that has to be defended against a pathogen coming from without is so dominant in our culture that when we ask lay publics to explain resistance, that's where they go. This notion that their body is the thing that resists pathogens and therefore resists antibiotics. So this kind of mashed together notions of personal immunity and antimicrobial resistance. So again, there's a problem here with the messaging. And I draw your attention to a couple of snippets. These are sort of more anecdotal kind of notions. So Google Trends tracks all kind of registrations in Google, Google searches around particular terms. So you can do a Google Trend analysis on anything. So I'm not pretending this is definitive, but it's certainly indicative of the prominence of personal immunity constructions in the publics. So guess where the peak is? Guess what date that is in the historical event that occurred on the planet that might explain that bump in interest in personal immunity. The other thing is that, our public institutions, public health organisations borrow this notion, boost your immunity, time to boost your immunity, something that now we're being encouraged to adopt in our personal lives. So running against this kind of tide of a notion of personal immunity as the way to protect oneself, antimicrobial resistance as a scientific construct runs into some conceptual problems. So the last thing I want to let you know about is the personal story. So we also spoke to people about experiences they might have had with prescribing infections, talking to doctors. We were really looking for those naughty people who ask for antibiotics when they shouldn't. We found that very few people were willing to admit that. So there's a kind of moral loading that occurs in and around antimicrobial use. Everyone has a story about someone else who might be using antibiotics inappropriately or blaming the doctor actually for, prescribing willy-nilly. So we had to kind of look beyond the kind of moral ideas about whether or not one should use antibiotics and just talk to people about how they use them and what they thought was going on. So I've got 4 little snippets to give you a sense in which how diverse public engagements are with antibiotics. And really, the antibiotic is not front and centre in these stories. Other things matter more than the actual drug. So the first one is Craig. He's an older man with chronic lung disease and a kind of lifelong pattern of disease and treatment. And he talks about his body as a clock. Just because I know my body or my body clock. And as soon as I get symptoms, I'll go and see my doctor to get some medication to try and stop myself getting the flu. All the doctors and GPs are going, no, because once I get it, I don't know where I am. It could have run off infections. I could have a run of infections. So Davina says, so what sort of symptoms do you have? And Craig says, I get really heavy breathing, affects my breathing, my chest gets heavy, I bring up heaps of phlegm, stuff like that. So Craig has a lifelong embedded pathway into the doctor, and maybe we can't know for sure what medications are being prescribed, but that's his body clock method. That's one kind of engagement. Another story we noticed came from Tamara, much rarer, probably more significant biologically, medically. And she gave us this story of an infection that she acquired at the beach. And it's so small, I can't read it, never mind. So Davina says, you had a foot infection, what happened? And Tamara says, I was at the beach, cut my foot on a really sharp shell. I think that there was some really nasty bacteria on the rocks and the shells at the beach, and something got in there. And it was like horrific. My foot was swollen. I couldn't walk for 2 weeks. It was really bad. It was quite traumatic. I was okay on the day of it. I was like, oh, I shouldn't really be walking on this. Cleaned it in the salt water, went home. The cut was maybe 2-3 centimetres, and I was fine. It was like on a Saturday this happened. I went to work on the Monday, and I was like, oh, it's pretty bad. Like, I can't really be on my foot right now. So I left work and went to the doctor because it was just getting worse and worse, like swelling, and there was a lot of heat, and it was like going a bit purple. And Davina says, and what did the doctor do and say? The doctor cleaned it and was like, this is pretty bad. We need to get you on antibiotics ASAP, or else it might go like septic. So this is not really a kind of member of the general population going, aha, I need antibiotics, but doing the kind of responsible thing of responding to something that was emergent, unplanned, an accident, monitoring it, noticing it, and then seeking support. So it's important we recognise that alongside the body clock man, we have the day at the beach situation. Another one was Diana talking about her daughter this time and being on holiday. Another set of social circumstances that prefigure whether or not an antibiotic is used. All sorts of questions there about emergency, finding a doctor, treating something, knowing what's going on, and issues around trust. So she's talking about what actually happened with her child while they were away overseas. And she says she was admitted and treated, and he, the overseas doctor, said it was probably the bacteria from the spider's mouth that was causing a reaction in her toe. And she had to have antibiotics. Otherwise, it would end up as a secondary infection, and it'd get worse and worse. I wasn't all that confident in his diagnosis, and I don't like to, especially with kids, I don't like them to go on antibiotics unnecessarily. But in the end, you kind of had to trust him. I was left without really a choice. So Diana's showing us that, knowledge about resistance, a reluctance to over-medicalise, that was all swept aside in a particular set of circumstances, overseas, a progressing infection, advice that wasn't sure whether she should trust that advice, but nevertheless, antibiotics were emerging there. So another set of circumstances that really point to how antimicrobial use is kind of produced in real life. The last one is Ingrid, talking about avoiding antibiotics. So I'm healthy with an autoimmune disease and caring for a child. I guess perhaps what people can do if it's sort of like a low-level illness without having run to the doctor, like the doctor shouldn't be sending someone home with a box of antibiotics, which of course they do all the time, don't they? They don't. They should be saying, go home and get under a doona blanket and take some vitamin C and perhaps some elderberry syrup. I don't know why elderberry is important. Or something like that. Like it seems to be people just want an answer, which is fine. I mean, like you go to the doctor because you want them to take care of you when you're sick, but I don't think the answer always needs to be antibiotics. This is another way of talking about the engagement with this technology and how significant it can be in life. And I think noticing these stories and the diversity of these stories is really important before we run into kind of, resorting to the myths, both about general public and about GPs in how they prescribe. So just to reflect on that a little, I suppose what we would have to say, thinking about how we talk about antibiotics in everyday life, news media interest is low and mostly focused on scientific discovery, which may not be helpful for trying to mobilise public action. Resistance to antibiotics is hard to explain and supplemented by long-standing notions of immunity as self-defense. That's the kind of keystone for lots of people. Antibiotics are not the main focus, it seems to me, in lived experience of infections. Other circumstances shape what happens, not individual predispositions to using antibiotics. So I suppose, and we're still negotiating through our findings and thinking about what we should say. I'm really keen to hear what you might have to say about these kind of issues. But I suppose what we would be saying is that we need help, communities need help about managing infections and antibiotics that define what they can do, that give them an agenda and a kind of set of steps that doesn't work against immunity culture, maybe attaches to that and uses it, given it's so prominent, and responds to the specific situations that people are in: chronic illness, emergencies, family life, travel, avoiding antibiotics, caring for a much loved pet, and so on. So I think from our research, this is how we're moving towards ways and methods of thinking about how to encourage action on this extremely important public health threat. Thank you very much.
Thank you so much, Mark. We will have a half an hour, or what time we have left, for a panel session at the end. So if you have any questions, we'll address them then. So next up, I'd like to invite Associate Professor Gabrielle Haeusler. Gab is an infectious diseases doctor at the Royal Children's and here at Peter Mac. So she's here to talk about one of her passions, which is improving antibiotic use in children.
Okay. Thank you. Thank you very much for having me. Okay, so I guess I would really like to start this talk by highlighting something that Kaz has already mentioned before, that antibiotics are certainly, and particularly in children, life-saving medications. And this is especially important for our youngest and most vulnerable paediatric patients, so really premature babies, infants and young children under 1, because they can be particularly vulnerable to really severe bacterial infections that need antibiotics. And these infections can come on quickly and make children really unwell quickly. And again, similar to what's already been said, that the antibiotic era has really enabled us to really push the boundary in what conditions that we can treat in children. We can treat cancers, we can treat relapse cancers, give multiple stem cell transplants to children now, and similar, obviously, in adults, do complicated surgeries and have paediatric children admitted to the intensive care unit for many, many months. And without that supportive care of antibiotics, many of those children would not survive. Unfortunately, as we're probably going to hear a few times today, and partly why we want to really spread the word about the appropriate use of antibiotics, that overuse and misuse of antibiotics in children is very, very common. And probably the most common reason that antibiotics will be misused in paediatric patients will be the treatment of an infection and a syndrome which is caused by a virus rather than a bacteria. And I think certainly a small COVID silver lining is that there's been rapid upskill of the community in what a virus is, and that it's different to bacteria, and that antibiotics don't treat viruses. So what are the common bacterial infections that we would see in children? And many of these are similar to what we would see in our adult patients, but some things that we might be, paediatric patients might be able to be treated in the community: urinary tract infections, skin and soft tissue infections, bone and joint infections. We can even give really short courses of antibiotics through the drip and get kids home really quickly on oral antibiotics. There are some misconceptions about other types of infections which people will often associate with a bacterial infection that don't need antibiotics. So throat infections are the most common cause of a throat infection in a child is a virus. that there are, with the exception of the strep throat caused by a bacteria that does need antibiotics. Ear infections can often be caused by bacteria in children, but the research shows that we don't actually need to use antibiotics, and they will often self-resolve within a day or two. So many children with an ear infection actually don't need antibiotics at all. Then there are the more severe infections and bacterial infections that these children need to be admitted to hospital and have really life-saving antibiotic therapy quickly. These are infections around the brain, infections in the bloodstream, and severe infections in the lung. We can treat many lung pneumonia infections in children in the community with oral antibiotics. It can be really difficult to differentiate some of these patients between whether or not they have a bacteria and a virus, and we don't expect families and parents to be able to do that themselves. That's really where they need to be seeking medical advice and having their child reviewed by a doctor to assess whether or not they might have a bacterial or viral infection. Things like prolonged fevers, really being drowsy and lethargic, poor appetite, although that can happen in kids for a variety of reasons, and rigors and shakes are often a sign that there might be something more serious going on. But what is sort of wonderful about this modern era of medicine is that many of these really severe infections can actually be prevented by vaccines. And I couldn't give a talk about antibiotic use in children without really highlighting the fact that there are now vaccines available and have been available for some time that prevent children getting some of the most serious bacterial infections. So much so that throughout my training in infectious diseases in paediatrics, I really can't even recall the last time I saw a patient with a certain type of bacterial infection that at the beginning of my training we were seeing causing really severe brain infections with really devastating complications and long-term effects. So vaccines are a really important way to prevent, partly prevent the overuse of antibiotics, but really to keep our patients and our young children safe. So what about the common cold? And I mentioned earlier that viruses are perhaps the most common reason why children will inappropriately receive an antibiotic. So there's lots and lots of different viruses that can cause a common cold. Many people that don't know that on average, preschool age children will have at least 6 colds per year. I've had preschool age children, I would argue with that 6. I think it's probably more like, 15 to 20, sometimes 2 at once, 3 if we're lucky. And as they're caused by viruses, antibiotics are not effective. And many people will have, if you've got a young child that lives in your house with you, will have that photo there will be quite familiar, and antibiotics will do nothing for that. It's time and letting the child get over the viral infection. And a common misconception is that if they're coughing up green or yellow phlegm or sputum, or their snot coming out of their nose is green or yellow, that's a sign of bacterial infection and needs antibiotics. That is not the case. Viruses can similarly cause that colour, phlegm and discharge from the nose. This, there's a led by a research group at the Royal Children's Hospital and the Murdoch Children's Research Institute, there is a national child health poll. So this poll polls at least 2,000 parents or carers of children on various different topics of importance in childhood. And they recently did a poll back in 2019 about using antibiotics. And you can see from these results that 1 in 4 parents incorrectly thought that taking antibiotics would stop a cold, which is caused by a virus, from becoming the flu, which is another type of virus, but a more severe virus. So that's obviously incorrect, but really common amongst people that thought prevails. And 1 in 8 parents report actually giving their child antibiotics to reduce the chance of even getting a cold. So that's giving a well child some antibiotics to stop something coming on, which is really quite concerning. How is this reflected across the country? So there are lots of ways we can look at national antibiotic use across the country. So again, going back to another child health poll, this one's a bit earlier, back in 2016, and you can see the number of parents there representing almost 4,000 children. And they were asked to reflect back on the last 12 months, and 43% of children received at least 1 course of antibiotics in the preceding 12 months. And not surprisingly, parents who thought incorrectly that their antibiotics were indicated for colds or the flu were more likely to have given their children antibiotics within the previous 12 months. So clearly some work to be done to re-educate people about what antibiotics need to be used for. More recently, and this is just really quite hot off the press, our national prescribing reports across the country actually show quite an improvement in the amount of antibiotics that are being used in the community. So 1/3 of Australians were prescribed at least one antibiotic course last year. And so that's across the entire age spectrum from children to adults. And that included 27% of children aged 0 to 9 and 19% of children aged 10 to 14 years. So you can see that there seems to be an improvement between that 43% results down to 1/3. However, Australia, despite what seemingly is a bit of an improvement, Australia still ranks one of the highest countries in the world for antibiotic use, ahead of Canada, England, and many similar countries to Australia that, in Europe. What about our usage in infants? So this is results from the Barwon Health Cohort study. So this is a large study based out of Geelong area, where they've tracked many hundreds of children that have been born in that area, gone back to the parents and asked after 12 months of age, has your child received a course of one or more courses of antibiotics in the last 12 months or the first 12 months of their life? And you can see Australia ranks much higher than many other similar current countries in our average number of antibiotic courses per child. And Italy is a country that has more high usage of antibiotics in this age group and much higher rates of antibiotic resistance. So why does overuse matter at all? Why can't we keep using this amount of antibiotics just to keep kids safe? So I think it's just important to recognise that every time anyone receives antibiotics, whether it's appropriate or not, there is a risk involved, and we will often as clinicians have to weigh up the risks versus the benefits. And patients with a really severe bacterial infection, absolutely the benefits would outweigh the risks. We think of risks at an individual level. So what is it doing to the actual patient? How is it making them feel? It can upset the tummy, it can cause diarrhea or nausea. Kids can go off their food and have a reduced appetite if they're getting antibiotics. But then we also think of the community risk, and this comes back to the point about antimicrobial resistance. The more that we are collectively using antibiotics appropriately or not in young children, the more we're going to drive resistant strains in the community. And the WHO has declared antimicrobial resistance as one of the top 10 global public health threats facing humanity. I think we are very fortunate in Australia, particularly in the paediatric area of medicine in Australia, that overall our rates of antimicrobial resistance are much lower than many other countries around the world. But I don't think we can become complacent and take our eye off the ball. What about other non-antibiotic resistance and other side effects of antibiotics? Giving antibiotics to children, what else can it potentially do and impact? So I'll take you through this graph slowly. So this is results of a very large review of all published studies that have looked at children that did receive antibiotics compared to children that did not receive antibiotics, and then went on to track a variety of different health outcomes that those children went on to have throughout their life. The authors of this review must have spent many, many hours putting together, looking at through 160 studies that included 21 different outcomes, and collectively all the kids that contributed data to this equated to more than 22 million children. And results suggest that antibiotic exposure might play an important role in the development of childhood immune disorders. And what do I mean by that? So you can see that this is what's called a forest plot, and this is where researchers can combine the results of multiple different studies that are looking at a similar outcome. And you can see on that line at 1 that those children that had received antibiotics, the lines are on your right, and those children that hadn't received antibiotics, the lines are on your left. And all the lines that are over onto the right side is more of a stronger association with that outcome if you had received antibiotics. Hopefully I've explained that okay. And you can see the ones that I've highlighted, things like allergic symptoms, food allergies, wheezing and asthma, as well as obesity and being overweight, psoriasis and arthritis. those children that had those conditions were much more likely to have been prescribed antibiotics in their childhood compared to children that didn't get prescribed antibiotics. Obviously, this is not saying that there's a direct, correlation doesn't necessarily imply causation. There is just that association. And I think it is important for us to pause and reflect back that, this over-prescribing of antibiotics, are we driving some of these conditions that we're seeing in children? And the authors hypothesise that this might be related to disruption of the microbiome in early life, but we don't know exactly why this association might be happening. So I think, to conclude again, I just really wanted to highlight, even though I've talked about some of the adverse and bad effects of antibiotics, that really they're life-saving and they're a foundation of modern medicine. Prevention is better than cure, another plug for vaccination in our youngest patients. There's certainly been some improvements in antibiotic use in children across Australia. It's not all bad, but we need to really keep reminding ourselves that antibiotics do not treat viral infections, and we shouldn't be using antibiotics to prevent infections in otherwise well children. And we need ongoing community education and an understanding of the right messaging to really improve our prescribing in this group. So thank you. Anyone, got to go to this. So there's a lot of resources available online. I've just put a couple of sort of my top 4 up here. Your family GP is obviously should be your first port of call, but there are some great health info available through the Royal Children's Hospital website, including results of other RCH polls. There's just been a recent poll about fever in children and how to manage fever in children, which people may find really helpful too. Thank you.
Thank you, Gab. A reminder that we are recording this session as well. So when it is made available online, we've got your email addresses from your registration. So we'll forward that link on to you all then. So next up is Professor Jason Trubiano. He's an infectious diseases doctor at Austin Health, and he has pretty much pioneered the way we address antibiotic allergies. So take it away, Jason.
Thanks, everybody. Thanks for having me. I'm an infectious disease physician pretending to be an allergist, so I probably know as much about allergies sometimes as everybody else in the audience, so we'll learn it all together today. And I'm going to start by describing some common allergies, and I bet many people would have had these allergies or adverse events during their time. And so the first one is potentially an upset stomach or diarrhea. The second, rash in childhood. Anybody that's had kids or been a kid might remember this. Another type of rash in childhood, often described as welts or hives, and then really bad stuff. And these are the patients we're all trying to protect. Severe rash where people can lose up to 50% of their body and spend many, many days in intensive care. But I'll tell you how this is rare, and most of our work is focused on the 1, 2, and 3. So I want maybe people to put their hand up and tell me which one they think is not a true allergy. So I've biased it. If anybody puts their hand up for 4, I'll shoot you. Can't be 4, right? So who thinks 3 is not a true allergy? Anybody think 2 is not a true allergy? Oh, I like that hand. Anybody think 1's not a true allergy? Yeah, good. That's good. All right, we'll prove that point later. 1 is not. 1 is a side effect. Many of us will get upset tummies or diarrhea or nausea and vomiting when we take lots of medications. But having that label as allergic means most doctors don't know and sometimes don't care and just give you the wrong antibiotic anyway. So actually empowering the patient to say, actually, it's not an allergy, it's a side effect, is one of the key things you could take away from today. Which ones are not likely to persist? What I mean by that is, which ones do we think you might grow out of? Might have been a true allergy, but you might have grown out of. Anybody thinks you'll grow out of number 4? No, keep the hands down. No. First 3, you can actually, while they look real and sometimes a bit scary with that red rash, you can actually outgrow most of those. And the last one, which one impacts our antibiotic choice? Well, it's a trick question because all of them, no matter which one we are labelled with, that label in our record, in our GP practice, at a nice fancy hospital like this, all of them will impact your prescribing. And so why do we worry about antibiotic allergy or antimicrobial allergy? Well, 1 in 4 patients that walk in this hospital door, and this is data from this hospital, will carry an allergy in their record. And when they do, they get the wrong antibiotic, unfortunately. And I've used the word superbugs there, but they get more drug-resistant infections. Unfortunately, in a UK data set, in a big UK data set, they're more likely to die, and they spend more time in hospital. So these little red armbands are not benign. We need to keep the red armband on the patient number 4. We need to think about how we can remove it from 1, 2, and 3. And that's because that 1 in 10 will have a true allergy, but 9 out of 10 will not. And so it's truly trying to find the 1 in 10 and remove the 9 out of 10. And so it does feel a bit like this most of the time, trying to find that one true allergy amongst a sea of false ones. And again, keep that in your mind. That's what we're trying to protect. That's the one we worry about. Everything else we're trying to remove. And so this is the most common red armband label you will see in the hospital setting, penicillin with the red armband. And most patients will tell you their story and about that red armband. Some of them have gone to the trouble of having it tattooed on. This is a patient of mine. They were not allergic. They had to have that tattoo removed. So it was a very expensive process. So here's the guy that invented penicillin those many years ago, first came into widespread in the 40s, particularly during the war. And when you look back at that first use of penicillin during those times, there were some early reports of rashes, urticarial hives or red rashes. And some cases of very bad reactions like anaphylaxis. Again, one of those severe ones we're trying to protect against. What's really interesting is they were doing skin testing for allergies back in the 40s, but we really haven't taken this up as a medical profession really, or made it in vogue until the last decade. And what's really embarrassing is that the way they did testing back then is identical to the way Bell's going to do it today. We have not advanced medicine in 70 years in the terms of skin testing, which is really interesting. And when I started doing this in 2015, exactly what I started doing in the old Peter Mackin clinic here. And what we have progressed to is really trying to understand, well, a lot of them are not allergic. How do we find those ones that are not allergic and do a simple thing and avoid skin testing, like giving a test dose, an oral challenge, we call it in hospital. And you'll hear from a patient today that's gone through that journey. And it's all about the truth and less about the bullshit. And the truth is that, like I said, most patients are low risk, and it's lies. And the biggest lie is my mum told me I was allergic. If I had $1 for every time that was said, I wouldn't have to be giving talks like this today. And many of them have gone on to have skin testing or being challenged. And of those ones that we find that we say are low risk, 1, 2, and 3, 97% of those will be negative on testing. Why is it? Well, there's 2 real reasons. One is they were never allergic in the first place. It was a virus that had at the time, but they were given an antibiotic. Gab told them they were allergic to penicillin when she treated them as a kid and they got a rash, and she was wrong. Or they outgrew it. It was lost over time, and that's true. And we know that 80% of people after 10 years will outgrow that allergy. And remember that number 2 and 3, they will outgrow those. The high risk ones, though, that's where we've got to protect, and we always got to have a safeguard. And they're ones like anaphylaxis. And I think it's like the story of the tortoise and the hare. It's the hare. It's quick. It's on and off, and it looks like that. And the one where the skin falls off, it's quite slow. Somebody can take that drug for many weeks and days, and then they end up in intensive care like this. One is caused by antibodies our body has, ready, waiting to catch the antibiotic. As soon as it catches it, all these cells release histamine, and that's what causes the hives and anaphylaxis. And the slow one is like the antibiotic comes along, your body decides to digest it, it presents it to the immune system, and then it goes berserko and creates this skin reaction here that we see, and that's because of our body's white blood cells. And what's really weird, we're in a cancer hospital, we obliterate all your cells, all your cancer cells go away, but you can still have these terrible reactions because they can live in our skin even though we remove them from our blood, and it has a memory of that reaction. And so the way I explain it to my son, who's heard me give this talk 1 billion times now, he says, well, Dad, which is the biggest baddie? Which is the worst of these ones? And that one is Stephen-Johnson syndrome, and I've showed you pictures like that. Second best is this name called DRESS. It's just a fancy name for saying a drug reaction where the internal organs are also upset. And the kind of cute one, the Loki, is the pustular rash. It happens a lot in kids, red rash, little white pimples, but it goes away quite quickly and it doesn't cause the problems the other two do. But for these, I don't want to give a little test dose to, like you'll hear Nathan talk about that story. I want to do some testing. I want to find who done it. I really want to find what caused it. And these are some more photos of patients like that. And we've got a long way to doing that. And the way we do that is with skin testing. And you can see some really positive results. And whilst I tell patients, don't worry, you get this big red angry spot in there, that's fantastic. We know what you're allergic to. And the spaces where there's nothing, that's great. That's the one I'm going to give you as a test dose so you know what antibiotics you're safe with. Because it might not be that we're going to be able to remove that allergy in that 1 in 10, but we're going to be able to give a safe prescribing for that. So that's what we do now. If I think about what we want to do in the future, we want to stop that. We want to stop that bad one from happening. And so this is a drug called vancomycin. It's a drug I hate. It was called Mississippi Mud. It was a dirty drug made in the US, caused a lot of reactions, still commonly used in hospital today. And this drug is used for staph or golden staph, and many people would have heard about that. And it can cause this reaction called vancomycin stress, which is effectively a bad reaction or allergy to vancomycin. And people can get very red and swollen like that from this drug. And what we've found over the times is that it's all in the genes. This might actually be preventable. And so this syndrome here, which is well characterized, actually we found a gene that predisposes to this happening. And so what we want to do in the future is find more of these, because wouldn't it be great? You walk into a fancy hospital like this, you have a blood test that tells you which drugs you can and can't have, and we prevent reactions like that. And when people come in with a story of 1, 2, and 3, we remove them at the door with a simple test dose. Now, you have to treat or test 75 people to prevent 1 case. But I bet if you tell that patient that had vancomycin stress, would they like those odds? They would, and they'd like a system to prevent it as well. So we have to get better as a healthcare system to do that. So what happens when we confirm the false and remove the false and confirm the true? Well, this is my last slide. We give the right antibiotic at the right time. That's what we're trying to do. Try and prevent resistant infections by giving the most simplest, safest antibiotics all the time. So if you are interested in more information, there's lots of patient information on our website here. I'm very happy to take any questions, or you can email me afterwards as well. But thank you very much.
Oh, yeah, sorry, that's fine.
I'll do
I wasn't sure.
Yeah,
if it
no,
was
I can-
that, that's
No,
fine.
I'm happy to introduce Nathan.
Yeah, happy to.
Well, it's a pleasure to introduce Nathan Fry. Nathan is a consumer. I don't really like that word, I'm sorry. He's a patient of ours. Nathan is a patient that's gone through a journey of penicillin allergy or drug allergy. And rather than me tell you about his story, what I think is great is to hear from somebody that's gone through that journey. And we're going to hear from Nathan today, which is a real pleasure. And thank you very much for making the time, Nathan.
So my name's Nathan and I'm not allergic to penicillin, but I thought I was. Whether I was when I was younger or whether I wasn't, I thought I was allergic to penicillin. And I think I've actually got probably the easiest talk to do of the day because I just literally get to talk about me. So this is a little bit of a cycle that I've gone through in my life. So I started off, obviously early days, being diagnosed with an allergy to penicillin, or what we thought at the time was an allergy to penicillin. As I got older, I developed an autoimmune disease called Goodpasture syndrome. And what that does is it's your immune system essentially attacking the lining of your lungs and your kidneys. Now, I was admitted with this and it's quite serious. So it affects about 1 in a million people, has quite a high mortality rate due to misdiagnosis. And I thought I was really special, right? Because they gave me the red band that said I was allergic to penicillin on it, like every time I've gone to my doctor, right? Now, I was treated for Goodpastures with a drug called cyclophosphamide. Now, cyclophosphamide in itself can be quite nasty with its side effects and everything else, but it's designed as an immunosuppressant. So it shuts down your immune system in a way that then your body obviously stops causing your organs to stress. Now, through that, it made me quite susceptible to infections and to chest infections in particular. And I got a chest infection. So I was actually hospitalized with pneumonia in probably March in 2007. And at the time, obviously, wasn't prescribed penicillin, which was probably one of the best drugs I could have had, even as a preventative. I was taking Bactrim, which is another antibiotic as a preventative. Anyway, came out of hospital then and unfortunately had a recurrence in 2014. Now, this time I was treated with a drug called rituximab, which is probably better than cyclophosphamide, but again, it fulfills a similar purpose. And again, I ended up with a chest infection. So preventative antibiotics are a really great thing, but unfortunately in my case, I was still struck down with that. Going on, I was pretty lucky then. So after 2014, it was quite a while before I had another recurrence, but I actually did my back. And I think doing my back was probably worse, to be honest, than what good pastures was. But when I went in for my back surgery, my anaesthetist got talking to me and he asked me about my red band. So what are you allergic to? And I said penicillin and he goes, are you sure? I'm like, well, yes. And he's like, no, are you sure? I'm like, oh, okay, you know. And he started talking about it and he shared with me the concept that if I wasn't allergic to penicillin and one day I needed a dosage of penicillin as a life-saving drug, it wouldn't be administered to me, whether I could speak or not, or potentially not be administered, which means that that could be worse. And he suggested that I undertake an allergy challenge. Now, obviously, my back was pretty sore, so I wasn't thinking a lot about it at the time. But as after I came out and that was all good, unfortunately, they gave me antibiotics for that too, obviously during the surgery and pre-surgery, so probably not penicillin. I then went into hospital again with good pastures. And what happened then was obviously went down my standard treatments, which is the preventative antibiotics, steroids. This time it was a drug called mycophenolate, so different again from the previous immunosuppressants I'd had. And I met Elise. So Elise came into my room and started talking to me about potentially, you know, would I be open to taking penicillin and seeing whether or not I was truly allergic, with the intention that hopefully I wouldn't be allergic and now it could be a life-saving drug for me. And lo and behold, after a couple of quick Zoom calls and signing, you know, being able to agreeing to it and everything else, I was given an oral challenge. And that oral challenge, I took it and I expected that I would start to feel a bit sick, a bit queasy. Actually, one day, there was once a dentist gave me penicillin and it gave me really bad heartburn and I thought it was my allergy, honestly. So I was kind of expecting a bit of that, thinking maybe it had gotten better over time. And I had no reaction. There was no reaction there, and it turns out I wasn't allergic to penicillin anymore. There was a little bit in me that kind of felt not special, that I didn't have my red band anymore. But cut it off. Yeah, no, it's gone. But since then, I've actually been able to take penicillin for other, you know, for other things that I've needed. So one thing that really resonated with me on this is that I've had good pastures in hospital now 3 times. 2 of those times I had a chest infection and the 3rd time I didn't. And it just kind of blows me away that over all the years, you know what you're taught and you go to your GP and they say, what's your allergies? And you write it down on your intake form and everything else. And, you know, to have an anaesthetist and Elise and her team come to me and say, look, this is something that we should probably look at, you know, let's get you off that list, was actually really powerful for me. So interestingly enough, my brother's allergic to penicillin, apparently, as is my dad, apparently, and my grandmother, apparently.
Your dad again?
Yeah, it's over there.
Well, 2 for 1, we can test you.
So just to finish off, I think I'm quite vocal about this, and it's something I'm vocal about when I speak to people in my workplace and to my friends and my family, because the amount of times, you know, people say, oh yeah, I'm allergic to this, or I'm allergic to antibiotics, or I'm allergic to penicillin. It's like, yeah, but you might not be. And the thing that makes a really big impact for me is that one day it could potentially save my life. So rather than taking the wrong antibiotic, I can now take probably one of the best inventions that as humankind we've ever come up with. So that's my story.
So that's that self-empowerment when you learn about how, you know, your issues and how you can deal with them and have a good understanding like Nathan. I think that's very, very powerful. Now we're going to have a quick 20-minute break. There's some sandwiches and drinks outside. When we come back, we're going to, I feel like doing a commercial break. Jason, who has never met my sister, so this is completely unplanned, is going to interview, what? Oh, completely unplanned, never met Steph, is going to interview her about her multiple allergies, and is actually going to do a skin prick test like he showed you up the front. And so maybe when you do come in, sit a little bit further so you can watch, and you can stand and around if you want to. I think it's really great for you to see it, just to demystify it, right? Because the way we actually run this program here at Peter Mac, and Jason is scaling it around Victorian hospitals, including Royal Melbourne, is that pretty much, as you saw, 90% of our patients with that red label can have them removed. And we do it two ways. One, we can, instantly delabel them based on history, or some patients need the skin prick. So when you come back after a little bit of a bite, we're going to step you through that. So thank you. All right, we'll have them outside. Okay, now for action stations. You are coming up now. So this is Steph. She's my sister. She is 6 years younger than me, and you're going to be sitting down there with a microphone. Jason, now Jason has never met Steph, and Jason's going to take you through the typical approach as to how he would assess a patient with an allergy, and the advice that he'd give. And you're going to see a live demo, and then Belinda over here is going to be doing the skin prick testing while Jason keeps on talking, because he loves talking. He won't stop talking, so we'll let him keep talking. You can also interact and ask questions. So if you want to know something more while that's happening, please jump in. There will be an opportunity to ask lots of questions. So I know I'm having a chat to you. Some of you are quite interested in this, particularly around questions around people interested about anaphylaxis and things like that as well. So Steph, why don't you go and sit down with Jace?
I've got the needles put away.
It's all right. It's okay.
I'll stab you later.
So I've got a microphone for you as well, but then just raise your hand if you want to ask a question, and I'll steal the mic.
Okay, all right. Well, Steph, welcome to our little allergy clinic here.
Thanks, Jason.
No, it's a pleasure to have you. And if you might, we just might skip the entire history. Could you just point to the picture of which one was your allergy? 1, 2, 3, or 4?
Well, it was close to 4.
Okay, all right. So that's a good start.
Not quite the start of.
All right. So maybe just tell us about what you think you're allergic to.
Well, I hate to say it might be penicillin,
Okay.
but also Bactrim.
Okay. Maybe tell us about the Bactrim story first.
Yeah. So it was interesting actually, because I'd had it once before with no incident. Went to my doctor to presented with chest infection. He prescribed it for me, and I took it for, it was probably 2 days. And then I was like, oh, tongue's stinging, like just stinging. And it sort of progressed more. I went to work the next day. I had some sushi, I had avocado. I'm allergic to latex, so the avocado is always a bit iffy for me, but I'll push on anyway. But it was really stinging my mouth, and I called Karen from the car when I got home, and I said, there's something going wrong. And she went, oh, sounds like the old thrush, or and she went, oh my God, you're having an allergy. I was like, oh. She goes, go inside, take an antihistamine straight away, and call me in half an hour. So by that stage, my tongue had started to ulcerate. By that night, I had ulcers the size of 50-cent pieces on my tongue. I could feel them down my throat. My eyes were sort of tending towards dark red. I had stiffness in my neck. My organs were aching. It was kind of terrifying. Yeah.
And did you have a rash at all?
No.
Okay, no rash anywhere.
Penicillin gave me a rash.
Oh, don't talk about that yet. Okay. So mainly mouth, and it took a few days to start and inside.
Yeah.
And it took a few days to get going.
Yeah, it did.
Okay. How many? You stopped the antibiotic then?
Yeah.
And did you go to hospital?
No, because I've got my sister.
I would have gone to hospital. No.
I would have, if I didn't have her, I would have been running to hospital.
She give you some steroids?
Did I have steroids? Yeah, I did.
She loves giving everybody steroids.
I know.
Yeah. Everybody. Steroids for you, steroids for
You
you.
got me credit, huh?
Yeah, that's Okay, all right. And how long ago was that?
That must have been about 7 years ago.
Okay. And why did you have the Bactrim? What were you sick with?
I think I had a respiratory infection or a sinus infection. I just can't remember because the Bactrim I took.
Okay. And never had it since? And would you ever have it again?
No.
Okay. We'll talk about that at the end. I think it's important because I could try and convince you to have all the kinds of testing in the world, but if you don't want to challenge that allergy, it's very hard to get rid of, which is really important. Okay, let's put that to the side because that might be part of that 4 one, right? Took a while to get going, slow onset, might have been due to the T cells, pretty recent, so it's not like you've lost it already. But it's definitely not anaphylaxis. Everybody thinks sometimes mouth things are anaphylaxis, but they generally happen after first dose quite quickly.
Not as loud as I think.
Not as loud as I think, okay. So I think we're going to put that to the side and we're going to say maybe in the box 4, could have been due to infection as well, but we'll leave that to the side. Tell us about penicillin.
So the penicillin was, that was when I was 17. Don't ask me what I had it for. I have no idea. I broke out in a full body rash, itchy, and I remember I was in the bath and Mum was pouring pine tar sol on me just to try and settle things down. I don't really recall how that played out, to be honest, but it was ascertained at that time that I had a penicillin allergy and I haven't had it since.
And I always ask patients these questions, but they never remember the answer, which is fine.
Yeah.
Do you remember if it was after the first dose or straight away? You can say no, most people don't know.
So long ago.
That's right, so long ago. Okay. And did you have to go to hospital?
No,
Do you remember having to have any treatment for it?
no, just probably baths and
Okay.
things to stop itching.
And did the rash, do you remember if it felt like a flat red rash like measles, or was it like hives and mozzie bites everywhere?
No, it was sort of more of a flat red.
More flat red. So that's looking like box 2,
Yeah.
flat red rash, might have been virus, might have been antibiotic, but a long time ago. And
Maybe a little bit sandy.
maybe a bit sandy, okay. And not that long ago, 17, so a couple of years ago.
So,
Okay. All right. So in my mind, we've got some scoring systems and we can add things up and each thing gets a little score. Did they go to hospital? Did they need treatment? Was it more than 5 years ago? Was it anaphylaxis, which is not? Was it box 4, those severe ones? No. And that would get about a score of 0. And we know if you have a score of 0, there's a 96% chance you're not allergic to penicillin.
that's exciting.
That is exciting. So for your kind of history, for that one, I would do what I did to Nathan, and I would actually just give you a test dose of penicillin, and we would see if you got a rash, and if you did, I would apologise profusely. But it's likely that you wouldn't get a rash at that point in time.
I would really like to not be allergic to
I
penicillin.
think so. Do you have any other allergies to antibiotics?
No, I don't tolerate erythromycin, but I put that in box 1.
Box 1, and you know that now, right? So we're going to say, and erythromycin is a shit drug,
Yeah.
and we don't use it anyway. So I like leaving people allergic to drugs they don't like using. So you can stay allergic to that. Okay. All right. So I'm going to leave you with the erythromycin, Bactrim. We might do some fancy stuff for you in the clinic down the track. But penicillin, we would do a test dose like Nathan. But we're going to show you the old school way today. Would you mind going old school? And that way we're going to do the skin testing.
I've done one of those before.
Okay. All right. Let's
But
go.
not for antibiotics.
All right.
I'm allergic to bees
Okay.
and grass.
None in here. Okay. All right, I'm going to get Belle to come over and do the prick testing for you. Belinda is our nurse practitioner who does all the skin testing in our clinic. She was taught really well how to do this and really is an expert in it. And I'll talk you through what we're going to do with the skin testing, and then everybody can see what we're doing as well. So what we're going to do for skin testing for penicillin, what we do is we drop initially a tiny little bit of the antibiotic on the skin. And it's not the full dose concentration, okay? You're getting a tattoo that lasts forever, okay?
I'll just add that to the collection.
Right, it's boutique. So we add a little drop of the antibiotics on the skin. And so they're not the high concentration, and it's just on the skin. And then we're going to prick you, little scratch. It won't hurt too much. And then we actually wait 15 minutes to see what happens.
And in somebody that's had a really bad anaphylaxis for a reaction, it should come up straight away. So I'm not expecting yours to come up at all. In the top box, we're going to put a little thing called histamine, and that is a control. It is what shows that your body's able to make an allergic reaction. That'll come up red. It doesn't mean you're allergic. It just says your skin can make an allergic reaction. So I can trust these results. So in 1, we're going to put that control called histamine. 2, we're going to put salty water, because if you light up like a Christmas tree to salty water, we're all stuffed, because that means you're making reactions to water. And then we're going to put penicillins in the other one, okay?
All right.
So Belle will do that. You're a bit slow today, Belle. What's going on?
Are those
It's
gloves
the
non-latex?
It's nerves, okay. All right.
They're non-latex.
Yes, we don't have any latex gloves. Okay, so the histamine goes on, and that should be actually quite itchy once we prick that. That's normal. It's supposed to be like that. Okay. And Kaz is not going to give you pred or antihistamines for a little antihistamine.
It's like a mosquito bite,
It is like. So we've got these little lancets. Don't worry, we've used them on 100 patients before you, so it's all fine. And so Bella's beautifully squeezed out a tiny little bit of liquid, about 0.02, 0.4 mils onto the skin in a little, and then prick. And we then let that liquid or those antibiotics sit on the skin for a little bit to go under the skin where we've made that little tiny drop. And so we do this, you can see here we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 12 boxes. And when we do this, there's many types of penicillin. So you might actually, some patients will be allergic to plain penicillin, but they could take amoxicillin or flucloxacillin. So it just means also, if you are allergic to one, it doesn't mean you're allergic to all of them as well. Okay. See, not too bad. Now, wouldn't it be nicer just to take a little simple test dose, right? Nathan got off lightly. So this is why we've moved to doing this test dose as much as possible, because while Steph's being a great egg here doing this, it's much nicer just to take a simple test dose, show you're not allergic, if you are low risk, which I think is for the penicillin. But it's really important to see that there are differences between the low risk ones like penicillin you've got and those severe ones like Bactrim. And that was a perfect example. I wish I knew that beforehand, that you were going to give both ends of the spectrum. Yeah. Now, is that getting itchy?
Yeah.
Yeah. Okay.
Yeah, it is.
What does it feel like?
I want to scratch it.
I want to scratch it. Now, if,
It's sort of like the start of a mosquito bite.
and if you were allergic to the other drugs, that's what they would do in those boxes. Okay. All right. So I don't think we want to wait 15 minutes for that to go red. And we might do a before and after.
Yes, what we'll do is we'll take a photo and then we'll load it up and show up in
Yeah.
about 15
Yeah,
minutes.
yeah, sure.
So you'll see what I can say.
Did anybody want to ask any other questions? Yes.
Would it make a difference if she wasn't watching?
If she wasn't watching, make her feel better or distract her?
Well, I just wonder, yeah, maybe distract.
Yeah. Sometimes some patients want to look and sometimes they want to look away. What I like doing is talking to the patients like we did during that time to kind of distract you, because the mind's also very powerful.
Because a lot of people, like Steph, you know, hers was only a few years ago, but if you've been told you're allergic to penicillin for 40 years, and then some smart ass is going to come up and say, well, actually, no, you're not allergic anymore. That's a very powerful thing to have to get your mind to overcome. So we're not only dealing with the allergy on the skin, we're dealing with here as well. So whatever it takes, sometimes I want to look away, sometimes I want to look at it. What would you want to do?
Didn't really hurt.
Didn't hurt? No. Good. The next bit hurts?
Yeah.
No. Any other questions? Okay. All right. Yes?
What happens when it's done? Like, what, you know, what do you do after this now?
So in real life, in clinic, we like this. This is a good test, but to be perfect, we actually then inject a tiny amount under the skin, which is also extremely safe. We wait again 15 minutes, and if that was negative, then we give a test dose. Okay. So that would be the additional process. So it's 30 minutes, then you get a test dose, an hour and a half is the entire process. And then you leave knowing that there's no life-threatening problem there to penicillin. And we often then give patients, we all give patients a telephone number to call in the next 2 days afterwards if there were any adverse events or any late effects or any rash. So that sometimes happens. Again, it's very rare, but that's the normal process. Yeah. Okay. For the Bactrim one, we would actually do sometimes, if Steph had a rash on the skin with also those mouth findings, we'd actually crush up the Bactrim and put as a little testos on the skin called a patch test. We don't do that as often as this kind of testing. There was a question.
What happens if the patient has more than one allergy? Do you test them all simultaneously or?
Until we run out of limbs, yes. Yes. So we can do a lot. So if we can do up to about 16 different antibiotics at one time, and then we have done additional ones on the back as well. But sometimes we do it over multiple visits. So for example, for Steph, we would do the penicillin first. You need that one, it's the easiest one to test. And then we would bring back for the other antibiotics over time. Okay, let's attack that class of drugs now. Don't worry about erythromycin, that one. You know, so we do it in stepwise.
Yeah, and so you were saying you're going to inject in the next step?
Yes.
There's 12 boxes, so is that potentially 10 injections or?
It's 10 small injections, yeah.
Okay, so you are injecting the
Yeah, absolutely. So we draw them up into these tiny little syringes. Maybe if we just show the syringe. And at the top is 0.02 mils. It's almost so hard to actually just get that small amount in. And that's what we inject under the skin. And it forms a little red spot. And we want to see that spot get bigger if you were truly allergic. And it gets quite dramatically bigger when the people are really allergic. So we try and really avoid this as much as possible because it was okay, right? But you prefer to avoid it. Yeah, yes, you would. Yes. Yes.
Sorry if anyone else, but would the nurse need adrenaline next to her work?
We have a kit here with all the emergency drugs if we need it. How many times have you used it, Belle?
I have never used it.
So that's pretty good, right? I think that, and it's all about that history at the beginning and selecting what risk people are and doing that. Yeah.
Have you ever tried doing this for a severe allergies?
Yes.
And what happened?
Yes. You shouldn't have favourites in terms of bad allergies, but they're the ones I like looking at, those really severe reactions. There was a photo on one of them where they had really huge red spots on the skin. So some of those severe ones will actually get those really red spots, and they'll actually sometimes have blistering around that. So that's the kind of severe reaction we would see on the skin. That would be one of the Steph's ones that was like that Bactrim one. It would take days. Maybe the next day she would send a photo and say, oh, number 6 is really red. Okay. For the people that have had anaphylaxis straight away, in clinic we would see that come up red. And Belle would see that, it would come up within maybe 5 or 6 minutes. Belle would knock on the door and say, oh, I've got one here, you know, penicillin's really come up. Again, everybody runs to see that because it's so rare. It's rare. Yeah.
What happens after with the information? To
Yes.
make sure that the patient and everybody that looks after them knows if they're not allergic or they are allergic.
We tell anybody that will listen. So Steph will leave the clinic with a card. It says what you're allergic to, but also says what you can take. That's really important, right? So we take the decision away outside the walls of the hospital. So the doctors can look at it and go, okay, Steph's allergic to Bactrim, but she can have X, Y, and Z. You also get a letter, and the same letter, I like sending the same letter to the patient and the GP. Why shouldn't the patient get the same letter? So they get the exact same letter, it says exactly what we did in testing, what they're allergic to, what they can and can't have, and then we send it to their referring doctors at any hospitals. Let's say Steph lived in Geelong, we would send it to the Geelong hospital as well, so they've got it on records. There's still gaps, you know, there's still some of my patients that will get re-exposed because a letter goes missing, but hopefully we then empower Steph, because she's gone through this, that she will take that letter everywhere when she needs an antibiotic and say, look what I'm allergic to, this is what I can have. There's a question behind you, Kaz.
If this has the ability to test 16, why do you prefer an oral challenge which is only testing penicillin?
It's a great question, because if you test the implicated drug, if you test the drug the person is allergic to, you don't have to worry about all the cousins and secondary drugs because you've gotten rid of the allergy. What all these secondary cousins and things do in those severe allergies, if they then light up to one penicillin, it tells me what other ones they can take. But in the low risk patient where I don't think they're allergic in the first place, Just give them the drug they're allergic to, and that way it removes it and they can take everything. Does that make sense? Yeah, it's a great question. One at the back has, and then, yeah.
For penicillin,
Yes.
I think it's pretty common that doctors will go to a different group and maybe
Yes.
completely if penicillin's on their allergy list. How common is it for those other types of penicillins that you mentioned, amoxicillin, flupox, etc.? How common is it that they won't have an allergy in that same family?
Extremely common. Steph is actually a perfect patient because exactly what happens. Oh, is it? It's a setup. You planted this. So, person gets allergic to penicillin. Then they go and get erythromycin and they have a side effect. And then they go and get Bactrim the next time. It's literally the 3 drugs people turn up with. And it's the same sequence of events and the same 3 drugs. But even if she was allergic, let's say truly to amoxicillin, the chance of being able to take plain penicillin is extremely high because it's only these little side branches of the penicillin structure people are allergic to, not the whole drug itself. So most of our patients, we say, okay, sorry, you're allergic to amoxil, but you can take everything around that. And most of our letters say, allergic to amoxil, but free to take all other penicillins. Okay? So it's not the end of the world, but the testing allows us to do that.
I have a question.
Yes.
Why is a person told they are allergic to penicillin as a blanket when there are so many other options within that family?
Yeah, because we were taught wrong. So we were all taught in medical school that if you're allergic to one penicillin, you're allergic to them all. And we were taught that if you're allergic to penicillin, this other family of drugs called cephalosporins, that there was a 10% chance. And that's absolute BS. We know that's wrong. So it's all about a re-education, unfortunately.
Mum wants to know,
Yes.
when should people have one of those charms or allergy?
Yeah.
When should you have?
It's really trying to prevent, if you were unconscious and you were allergic, you wouldn't want to give them that drug. And that's what I talk about for that. So what's that scenario? So there are drugs like penicillins or cephalosporins that you might get in the back of an ambulance, or you might get if you're rushed to hospital for surgery. So that's the ones that I do the charms. And also number 4, I do a charm for number 4. A recent patient of mine kept breaking her charm, so she thought it'd be a great idea to get a tattoo. And it's not that one I showed you, and she got this huge forearm tattoo. Like, oh, I think you should do that. Anyway, she doesn't have to worry about a charm anymore. Any other questions? Okay. And now, is it red just before the end? Yes, nice red spot. So you've got beautiful skin, and the other ones are all negative. So all the other are negative. So far, not allergic to penicillin. Okay. Thank you, Steph.
Okay, you can't see it. Yeah, we just can't see it. While that's getting set up, at our National Centre for Antimicrobial Stewardship, as Kaz mentioned, we aren't just about humans. Antibiotics are used across both the human and animal sector. So our next speaker is Dr. Ree, who is a veterinarian, but is also doing her PhD on improving antibiotic use in animals, specifically companion animals. So your everyday pets.
Sorry, I just...
No, that's fine. We want it to work, so.
Yeah, I'm gonna have to close this.
As long as the Zoom's not closed.
Zoom's not gonna close, that's
Yeah,
fine.
perfect.